Okay, thank you. Good morning. This is the Central District Board of Health meeting for Friday, March 19th, 2021. It is 8:30 a.m. I will introduce myself. I am the presiding chair, Betty Ann Nettleton, representing Elmore County, along with Representative Megan Blanksma. At this point, I will call the meeting to order, and we will be taking a roll call by county. Valley County.
Commissioner Hasbrook here.
Thank you, El. Boise County.
Commissioner Sturm here.
Thank you, Ryan. Ada County, Dr. Young.
Jane Young, present.
Thank you. Dr. Epperly.
Ted Epperly, present.
Thank you. Mr. Labrador.
Raul Labrador here.
Thank you. Elmore County. I'm not hearing Megan yet, so we do have a quorum, and we'll proceed with action items. Changes to the agenda. Director Duke, do we have any changes to the agenda?
Madam Chair, no changes to the agenda today.
Okay, thank you. Proceeding under new business, I will be asking for a motion and a vote regarding the February 19th, 2021 board minutes. Do I hear a motion?
Madam Chair, this is El. I'll make that motion.
Okay, thank you. No corrections or additions to those minutes, I'm assuming. And hearing none, I will go ahead and ask for a second.
I'll second.
Okay, thank you, Ryan. We'll call for a vote by county. Valley County.
Commissioner Hasbrook, aye.
Boise County.
Commissioner Sturm, aye.
Ada County. Jane Young.
Jane Young, aye.
Ted Epperly.
Ted Epperly, aye.
Raul Labrador.
Raul Labrador, aye.
Elmore County. Okay, Megan's not there. The minutes for our February 19th, 2021 have been approved. And proceeding on, we will go to Laurel McMahon, who is our Support Services Division Administrator, to provide us with our financial reports. Laurel, the floor is yours.
Thank you, Madam Chair. I'll go ahead and go into the start of the report while we wait for it to come up on the screen. So just as an overview of the report, it does go through February, which is 67% of the fiscal year. Here it comes. Okay, so trends this month continue to be similar to what we've seen all year. Continue to see the same impacts from COVID funding. However, this month, what you'll notice is that the budget revisions that you approved during our last meeting have accounted for some of those differences. So you'll see the percentages a little bit more on track with what we'd expect through this point of the year. And to continue with the overall summary, page 1 shows that our revenues are still a little bit higher than planned through this part of the year. We're at 78% of budget, and expenditures are right on target at 63%. Going into a little bit more detail on the revenues, our other revenue for support services, that's showed up the same as it has for the last several months. That's from Idaho Power rebates, that auction revenue, and that auto sale. We're at 100% there because we don't anticipate any change for the rest of this fiscal year. For community and environmental health, you can see that the contracts and fee percentages have come down since last month, and that's because during the budget revision process, we adjusted for that. Other is still high due to the WICC, Millennium Fund, Citizens Review Panel, and that has stayed about the same as what you've seen the last several months. In family and clinic services, our fees and contracts are close to the planned amount. You'll notice here that fees now show on track with the budget, as that budget number was revised as well to account for providing those more limited clinic services such as dental care than we would in a typical year. Our other revenue is high, and that still includes those home visitation funds, and total revenue in FCS is above target at 76%. And then moving into expenditures, here again, you can see where the budget revision changes have made some differences in the percentages from what you'd been seeing. For administration, our personnel and operating budgets were revised to account for our charging differences, since more of those staff were charging to COVID response than what had been planned initially. So that now appears on track as we want it to. Support services, same for personnel and operations. Our revised budget has been accounted for. And the capital budget now does show our funds there that are planned for completing the remodel and parking lot repairs. So that percentage is on track as well. For community environmental health, our personnel and operating are also adjusted due to the COVID funding. And then moving on to family and clinic services, personnel and operating are also right on track. Going to page 2. Okay, and this is the same comparison over the last couple of years. In CDH, you can see that the fees have been mostly consistent from last year to this year, with the exception of sewage disposal, which is over 90,000 above where we typically are at this point in the year, and everything else is pretty much on track. For FCS, you can see this is the same as we've been seeing, same trends, the increase in central care and the reproductive health services. We've got decreases in immunizations due to the school-based vaccine clinics going down. And then where you see the biggest impact is what we've seen through, again, the last several reports, where the child dental clinic has just received that biggest impact. We are starting to pick that activity back up again and have been able to do some in-school clinics over the last couple of weeks. So we expect to see some change there, but it still won't get back on track to what it had been in previous years, at least for the end of this fiscal year. See, under contracts, you can see the difference in community environmental health compared to the last 2 years, and that's where the COVID funding really shows up. All right, moving on to page 3, the cash balance statement. And this again shows the changes that were approved during the budget revision process. The reserve fund designations have changed based on what you approved at the last meeting. And we received the second half of the state appropriation in January, so that's all reflected in this report as well. The cash balance less the reserve fund leaves a balance of 2.8 million in the undesignated cash balance. Okay, and we can move on to page 4 of the financial report. And this page has stayed the same over the last several months. And same report as I've been providing, that we do still have a plan to finish up the remodel with the carpet, paint, and furniture, and haven't been able to do that yet just because of the high utilization of our facility right now with the extra staff in the building. Okay, and we can then move on to the COVID funding summary. And then I can open up to questions on both. Wait for that to come up on the screen. And this report we went over a couple months ago. There have been some changes since the last one. So this is just a summary of what we've received in COVID funding. All of these funding or grants that you see on the screen are all federal funding sources, with the exception of that Pacific source, the small grant that's about halfway down the page. So other than that, those are all federal funding. Just a few things to note on this report. The CARES Act funding ended December 30th, so the unused funds were cleared out there. And the rest you can see where we have balances. And some of this funding is planned to go through spring to summer timeframe of 2022. So it is anticipated to carry us through that time period. And with that, I will go ahead and open it up to questions, Madam Chair.
Yes, go ahead. Floor is open for questions for Laurel.
Madam Chair, go ahead.
Yes, go ahead, El.
Laurel, I just had a question on the front page, the county contributions. They're in at 100%. Is that normally when those come in? The reason I ask that is because if we get this bill through where the counties are going to be paying that whole bill, that's may be liable to change. It may be spread out a little bit further. But one of the big arguments on this bill is whether to start it to July 1st or January 1st of next year. it looks to me like either one would be okay. We would still have 100% of the county funding. Is that kind of how you're feeling?
Yes, that's correct.
So it should continue. We can use that. Okay, that's all I have.
Okay, thank you, Al. Any further questions for Laurel?
Kitty Ann, this is Ted Epperly. I've got a question.
Oh, yes, Ted, go ahead.
Thank you. Laurel, in regards to the American Rescue Plan that was just passed by Congress, do we have any sense of, I know that Idaho is online to get about $1.3 billion in round numbers. Do we have any sense of how that will be distributed to public health, parts of those funds, and what might eventually come to Central District Health?
Madam Chair?
Yes, go ahead, Laurel.
So far, I do not have any sense of that, Dr. Epperly, and I'm not sure if Director Duke has any additional insight, but I haven't heard or seen anything that would indicate funding amounts that would come directly to public health from the American Rescue Act.
Okay, Russ, do you have any comments on that?
I don't have any information specific to funding amounts and for what purposes at this time.
Okay, thank you.
Madam Chair, this is how I can help a little bit there. The information that the counties are getting is it's going to be 2 payments spread over 2 years. The last we saw, and Seth would be the guy that had this information, is in our case, Valley County would get about $2.3 million. But like I say, that's going to be spread over a 2-year period. There are some really limiting restrictions on where you can spend that money, but it does have to be kind of COVID related. And I guess the recommendation the counties are getting is it's one-time money, so try not to build it into a budget of maintenance, that it's not going to be there year after year. I don't know about getting money to the health districts. That may be a possibility. I don't know. I'd have to see what the details are on the limits on how you can spend that money. But it deals a lot with COVID-related expenses, including salaries, emergency salaries, broadband, sewer, and water, and there was one more, and I can't think of it now, but, you know, we've been talking about it in our area, and probably what we could use it for mostly is for employee housing. That's one of the options you can use it for. So that's still, it's all premature. We haven't really seen those come out yet to know where we can and can't spend the money. That's all I got.
Okay, thank you, Al. Any further discussion or questions for Laurel? Hearing none, I will move on to Natalie's report. She is our Public Health Preparedness Program Manager for a review of vaccine status and distribution update. So go ahead, Natalie. Dustin, is Natalie connected?
I'm showing her connected, but I'm not showing audio coming from her.
Okay.
She might be on mute.
Yeah.
If Natalie's unable to join right on the Q link.
I'm sorry, I was getting a lot of static there. Was that you, Russ?
That's correct, Madam Chair. I was suggesting move on to the next agenda item, which is late while we work out any technical issues with Natalie.
Okay, that would be fine. If Kim is ready, we will move to her report, which is a review of COVID-19 status. Kim is our communicable disease control manager for those of the public listening in. So go ahead, Kim.
All right, thank you, Madam Chair. And Dustin, if you could pull up my slide deck, please. And I know I will say to the group, I've had a couple of times where my audio's dropped out as well. So hopefully we'll make it through this without having any technological issues. So providing the monthly COVID-19 at the update. Next slide. So the first two slides that I have are looking at our hospital numbers, and as of last month, our non-ICU census was not quite back to pre-surge levels. We've seen those numbers of Ada County residents hospitalized. Those are continuing to go down, and we are back at pre-surge levels at this point. So looking good on the hospital front. Next slide. So looking at our ICU numbers, Ada County residents again, and as of last month, we were back at pre-surge numbers of hospitalizations, and that continues to be the case. Next slide. So switching gears into looking at our COVID case counts, and I broke these out by county. You'll see we did have, starting out with Ada County, our numbers have come down quite significantly from where they were over the winter. Our low point that we've had most recently was 353 cases reported a couple weeks ago. Our numbers have gone up a little bit since then, though. So last week we had 588 cases reported among Ada County residents, and this week we're looking to be on track to have similar numbers. As we look at this, of course, you know, it's easy to see those numbers have come down so much from where we were over the winter. But I do want to point out, I include the red line on these graphics. That is the marker for each of the counties. That is 100 cases per 100,000 residents per week. And that's our indicator of where we're seeing significant levels of community transmission of COVID. So what you can see is that in Ada County, we did drop below that level. However, we're back up above it again. So we're in a position when these numbers start going above that line, that we might be in a position to start seeing surges and increased numbers of larger outbreaks and clusters within the community. So of course, staying below that is definitely our goal. Next slide. So looking at Boise County, we've had a number of weeks where the number of cases being reported is in low single digits. This past week, we were at 7 cases, which is right at that 100 per 100,000 mark. So as far as Boise County goes, it would be nice to see them drop a little bit lower at this point. Next slide. Elmore County, kind of a similar trajectory. Right now, they are staying below 100 per 100,000 cases, but you'll see that we're close to that line. So 24 cases being reported last week. Next slide. And for Valley County, again, very similar trajectory. We saw those numbers come down quite a bit from the peak of where they were in January, dropped below 100 per 100,000. And among Valley County last week, 11 cases recorded, which puts them right at that 100 per 100,000 mark. So again, across all 4 of our counties, we've seen numbers come down significantly. However, we've seen increases from those low points where they were. So we still definitely need to be keeping an eye out on case counts across all 4 counties. Next slide. So as our cases are lower, as they're staying near or below that 100 per 100,000 mark, we're able to gather good information from our interviews with people who are testing positive. And we're able to look at where their most likely exposures occurred. Right now, the information that we're gathering isn't too different from what we were seeing last month. Definitely the top exposure location is within households. We know that COVID does spread very easily, potentially in a household setting. It's not impossible to prevent transmission, but it is definitely more challenging. And as we look at prevention of COVID, again, knowing that household transmission is going to be one of our main drivers of infection, looking at how did COVID get into the household itself? So looking back into the community, looking at other exposures, and that's going to be one of our main ways of continuing to message about prevention measures. So again, we're seeing small gatherings being one of our common exposure locations. These are occurring both in private settings, so people visiting one another in their homes, but it's also occurring out in more public spaces. So we're seeing many more reports of people going out, birthday parties at event centers, people going out to bars, restaurants, and other public venues, and that's where we are seeing transmission of COVID. Again, as with last month, workplaces are continuing to be an area of concern where we are seeing most likely exposure coming, typically from situations where we're seeing that combination of inconsistent mask wearing, not able to be physically distanced from one another or not choosing to be physically distanced. And again, things like small group meetings, people having lunch with their coworkers, and any number of different scenarios that are causing workplace transmission. And the last area of common exposure is our community transmission. You know, again, as I mentioned, as we're looking at those case numbers being above that red 100 per 100,000 line, that risk of community exposure goes up and community transmission increases. So these are people where when you talk to them through the course of the interview, there isn't a most likely exposure that comes up. These are people who maybe they go to the grocery store every once in a while or, you know, out to the bank, and there's not necessarily a way that we can connect how they picked up their COVID. And again, as those numbers increase within the community, this is going to continue to increase as well. Next slide. So I want to switch gears a little bit and focus a little bit of time on talking about variant viruses. This is something that has been of interest locally and nationally. So CDC just very recently put out new information where they're showing the data about the proportion of variant virus strains across the US, and they've done it over a timeline. So I took the information from CDC and made a simplified graphic of what's going on with variant viruses. And on this graphic, what you'll see is it runs from the beginning of the year through the 27th of February. For color coding, that gray bar those are our common COVID strains that have been routinely circulating. You'll see the yellow is what CDC is calling variants of concern or interest. These are variants such as the ones that have been detected coming out of California. This is the B1351 strain that was detected out of South Africa, P1 strain that came out of Brazil, and other ones that they are looking at. And then the red bar is the B117 or the UK strain. So what you can see is that starting at the beginning of the year, these variants were making up a very small proportion of the amount of virus that was circulating in the US. And it's just been a slow and steady climb over the past 2 months. And now where we're sitting is that nearly 30% of the circulating virus in the US are these variants that CDC has deemed variants of concern. And of course, this is important from the standpoint that this B117 UK virus, it's predicted to become the predominant virus that is circulating here in the US. And it's definitely on track to do that. I think over the coming weeks to months, we are going to see that the B117 strain continues to become more prevalent. And of course, that's of concern not only because of the fact that it's more transmissible from person to person, but we're also seeing additional mounting evidence to say that this variant causes more severe illness. So this trend is definitely concerning and is going to be playing a role in virus transmission and COVID illness throughout the U.S. Next slide. So pivoting to look at the variant strains and what's going on locally, we are seeing additional variant strains being reported. As of this week, we've received word of 9 individuals whose specimens did show that they were infected with this B117 strain. I know that Dr. Peterman from Primary Health has been very vocal in reporting that they are continuing to see increasing numbers of specimens that are suspicious for the strain and being sent for the sequencing. So I think that's something that we are going to continue to see, and that is going to be an increasing trend. An additional point, as we look at these new cases that have been detected, we're seeing that local transmission is occurring. So when our first individual who had the UK variant was detected, this was a person who traveled out of state. We believe that that exposure happened out of state, and that's no longer the case. We are seeing that these people are picking up their COVID here locally. So the trend that we see nationally, I think, is one that's going to be echoed here locally as well, that the variant strain, specifically that B117, is going to become more predominant over the coming weeks and months. Next slide. So I want to switch gears again. CDC did put out new recommendations for fully vaccinated persons. I think it's important, as we look at the data, to be looking at what's going on the prevention side as well. So when we're talking about a person who is fully vaccinated, as a reminder, this is an individual who's gone through their full vaccine series. So for the Moderna and Pfizer, that's having 2 doses. And for the Janssen vaccine, that is 1 dose of vaccine. And then they've gone 2 weeks past that. So their body has had that opportunity to develop full immunity. So for our fully vaccinated persons, we know that they no longer need to quarantine if they've been exposed to COVID. And I think this is important as we look at how we resume normal activities in public. The fact that these people are not having to take that time out of work, having to take that time away from other public domains. But people do still need to be isolating and get tested if they develop symptoms. These vaccines are good, but they're not perfect. So we do want to make sure that if there is a concern that a person has COVID, that they get checked out for it. Another thing that this guidance document included is the indication that it's safe for people who are fully vaccinated to privately socialize indoors with other fully vaccinated people. And they can do this without masking or physical distancing. And again, as we look at those social bonds that have been in many ways severed as a result of COVID, I think this is an important step forward. The one thing that the guidance document did make a point to include is, unfortunately, we're not at the point yet where we have enough vaccine in the community that masking and physical distancing can go away when in public spaces. So anytime that people are out in public, regardless of fully vaccinated or not, people should still continue to wear a mask and practice physical distancing. Next slide. So just to wrap things up as a summary, our hospitalization numbers are looking really good right now. Unfortunately, like I said, we do have all 4 counties reporting increases in the number of cases. And what this means is that we can expect that hospitalizations are going to increase probably over the next week or 2. And of course, those hospitalizations, as far as the total number of people, is going to be really dependent on our number of cases. I think as we look at increases, it's important to note that our area is not the only one in Idaho that's being impacted right now by increasing numbers of COVID. Over in eastern Idaho, they have alarmingly high case rates that are occurring right now. And I know that it's starting to impact their hospitals as well. And I think that's something that we need to keep a close eye on, not only because that is something that could potentially happen here again, but the fact that we're moving into spring break and we know that there are going to be people who are coming and going between our 2 areas. So there is a possibility that we may see COVID exposures and also transmission occurring as a result of spring break type travel. As I mentioned, we do have increasing numbers of the B117 variant that are being detected in our area. As far as what those impacts of local transmission and hospitalizations, it's really unclear. I think we potentially have an opportunity to look at what's going on in other areas of the United States and gain better understanding of how this variant is spreading and how best to prevent it. In terms of our prevention measures, though, the foundational public health prevention measures still are in place. So looking at masking, physical distancing, and vaccination, and those really are going to be the core components that get us through this. You know, we're not quite through the woods at this point, but we are continuing to get more people vaccinated. And until then, we really do just need to be continuing to be consistent with our masking and physical distancing. And that's the end of my report. I'm happy to take questions.
Kim, this is Betty Ann. Could you comment further on the age set that the variants are targeting?
Sure, Madam Chair. So when we're looking at this, it's not discriminating to a specific age group. These variant viruses are more transmissible across the board. So when we look at an adult, they need lower amounts of virus to become infected and to become infectious. With children in COVID in general, they aren't necessarily as susceptible to becoming ill with it nor transmitting, especially as we're looking at our younger kids. But with these variant viruses, that level is decreased, but they aren't immune from it. So this is something that we're looking at across all age groups.
Okay, thank you. The floor is open for questions or discussions for Kim.
Madam Chair, this is El.
Yes, El, go ahead.
Kimberly, on the variant strains that are coming out, can you tell us which vaccine will work the best? I've heard that AstraZeneca, can't say it, covers most of the variants and some of the others don't. Can you explain that so the public knows?
Sure, Madam Chair, Commissioner Hasbrook. So we have 3 vaccines that are currently licensed here in the U.S., and those are the Moderna, the Pfizer, and the Johnson & Johnson or Janssen vaccine. All data right now is indicating that these vaccines do provide protection against the variant.
All 3 of them do, is that correct?
That's correct.
Thank you, that's really good news.
Yes, thank you.
Madam Chair, this is Raul.
Yes, Raul, go ahead.
I just have a question about the recommendation from the CDC to wear masks after you have received the vaccine. Have we done any independent studies on that? Or it seems that if we want to encourage people to vaccinate and we tell them that they still have to wear a mask, that's actually a discouragement from vaccinating. There's no reward in vaccinating, so people are less likely to do it.
Madam Chair, Mr. Labrador, I think what we're seeing is that the CDC did come out with the recommendations to say that if individuals are socializing in a private space, both are vaccinated, that masking isn't necessary for those people. What I think is going to happen as we have a higher and higher proportion of our population becoming vaccinated, that we're going to see that need for masking is going to go down. So there is definitely a benefit to the vaccine. It's just a matter that we have a lot of people who need to be vaccinated before we can do away with masking.
Follow-up, Madam Chair?
Yes, go ahead.
And this may be just a comment for the board. We need to look at this really closely by the next meeting. I think if people are being vaccinated and they're also being told that they have to wear a mask after being vaccinated, I think that's going to be a discouragement to our public. And it doesn't really make sense. It shows that we don't have faith in the vaccine. So I think we should really look at this closely and remember that CDC is just a recommendation, that we're an independent body and we can make decisions different than the CDC recommendations.
Betty Ann, this is Ted Epperly.
Yes, Ted, go ahead.
Yeah, I've got 3 quick comments and a question. First, in regards to the the variants and your question, Betty Ann, in terms of children. And I appreciate Kim's response that the variants are kind of non-picky. They'll infect anybody that will allow them to get infected, if you will. But what the experience in the United Kingdom and Europe has shown is that the number one group in regards to the uptick in the B117 variant are in children. And that age group is 5 to 12. And the second most common age group in the UK and Europe with the B117 are adults that are age 30 to 39. And what's happening and what's driven the response in Europe to a large increase and, if you will, a fourth surge is that the kids who are getting infected are taking it home to their unvaccinated parents in the 30 to 39 age group. Now, this becomes important for us to at least be aware of because, again, both of those age groups are unvaccinated. And so where we might start to see not only the plateau, but the uptick that Kim showed us is in a transmission cycle that could be happening and has in Europe and the United Kingdom between kids and their younger parents. So that's comment number one, and I think it's important for us to be aware of as we watch this. The second comment that I'd like to make is in terms of Eastern Idaho. Kim is exactly right. Eastern Idaho has become one of the biggest hotbeds in the United States. In fact, this morning, as reported, Idaho Falls ranks number one as in the United States as the highest transmission of any city in the United States, with 55.9 cases per 100,000 that are happening there. So I just want us to be aware of that. Rexburg was like number 4 on that list, and number 2 is New York City. So I just want us to be aware that Idaho is on the map. We have a lot of community transmission that's still happening in our state. Comment number 3 is in regards to Raul's question about masking. And I would say, Raul, to you that part of the reason that we still need to mask even after we've been vaccinated, at least at this point, is that we're also not clear exactly how effective the vaccines may be against all the variants. It's not exactly clear. We just don't know. And so part of the rationale, and Kim pointed this out, in small social gatherings, families, group sizes 8 to 10 people vaccinated, okay to take off the mask, but in public, because we're not absolutely clear on the impact of the variants and the vaccine's protection against the variants, that's part of the rationale too, Raul, why we'd want to be careful about wearing masks until this is a bit more clear. The last thing I'm going to say is my question, and that is that in looking at the numbers, I'm a little bit concerned with the uptick. I think we all are. Could this be the beginning of a fourth surge? Not sure, but the variants are out there. The variants are increasing. And so the question I have, Betty Ann, to you and the board and to Russ is, should we have another meeting in 2 weeks versus 4 weeks, just so that we can keep an eye on what's happening right now? I'm concerned that we might be seeing an uptick that could become substantial. And I just wonder if we may not want to meet a little bit earlier than 4 weeks from now. And I'll stop with that.
Jeez.
Okay, thank you, Ted. Any further comments, questions for Kim?
Thoughts again.
Yes, go ahead, El.
I'm wondering, Ted, if this isn't a situation why we're getting the uptick is the fact that we took the mandates off in in the counties, not necessarily McCall or Boise, but in the counties. And so we're seeing a sign of the result of that. Pure speculation on my part. The other concern I have is if we start relaxing the mask guidelines, there's going to be some political concerns that jump into this, and I don't want to politicize any of this, but if you're in a public facility and you've been fully vaccinated, are you going to be able to walk around that courthouse or that city hall while your counterparts aren't because they haven't been vaccinated? I don't want to get to that point. We've got to treat everybody the same. So I think, as far as a policy, I still think it's a great policy to keep recommending that people wear masks until we get clear through to kind of the end of this. It's an easy thing to do, and I think just the opposite, that if you got to keep wearing masks until we get everybody vaccinated, that's going to put a lot of peer pressure on folks to say, you need to go in and get vaccinated so we can get rid of these damn masks because we're all getting tired of them. So I think it kind of works the other way too as well.
Yeah.
I'm done.
Madam Chair, it's Russ.
Yes, Russ, go ahead.
Yeah, I was waiting, I guess, for a response from the board about meeting in 2 weeks. And I would ask the board or Dr. Epperly what the purpose of that meeting would be. We meet a month from now. If, for example, we start to see a continued steady increase in cases, is it the board's preference to meet just to be aware of that, to make the public aware of that? Because there's other means we could do that, email communication, press releases. Or if the board is contemplating reissuing orders, because that's your authority to do that, then I would say that would be a good reason to meet in 2 weeks if, again, we saw a steady and sustained increase in cases throughout our health districts.
What did you drop?
I'm sorry, somebody was speaking there. I couldn't understand who it was.
Madam Chair, I think it was Ryan. He was unmuted, but he's on mute now. But I finished my question back to the board as far as your preference, and certainly I'll take direction as always.
Russ, Madam Chair, sorry, Betty, this is Ted.
Go ahead.
Yeah, just a thought, Russ, to your question, and you're right. We want to be clear on purpose. Why would we meet? What I'm wondering is if we are correct in regards to the numbers plateauing and starting now to increase as an early fourth surge, which, this may well be. We ought to know in the next week or two what's going to happen here. Kim had mentioned that the numbers coming in this week look to be about where they continue to be with this uptick. In other words, not the continued drop, but a plateauing to an uprise. Russ, the purpose for me would be, if that's the case, we see and I'll just play this out, a rapid escalation in the next 2 weeks. We already know Idaho Falls and Rexburg are the highest, in the top 4 highest places in the state. We're starting to see increased community spread in Boise. We have wastewater data that shows more variants. What I'm wondering is if we shouldn't meet to contemplate the potential escalation of an advisory to an order based on that, so that at least we could be, 1, aware of the data, 2, aware of the direction and trend, and then we could meet to reconsider our position right now as an advisory. That would be my thought, Russ, at this point in time.
Further thoughts from board members?
Madam Chair, this is Raul. I don't think a meeting.
Raul, go ahead.
Thank you. I don't think a meeting is necessary in 2 weeks. I don't think there's any evidence. You're seeing cities like Boise that have a mask mandate that are also seeing upticks. So there's no difference between cities that have mandates and cities that don't have mandates. I don't think the mandates work. I don't think we need to come back in 2 weeks to reconsider this. I think people are doing it on their own. For the most part, everywhere you go, people are wearing masks and they're complying. I think you teach people correct principles and you let them govern themselves. I don't think we should be in the business of mandating masks. And you will see no difference between cities that mandate and cities that don't have mandates.
Further
Madam
thoughts
Chair,
from the
this
board?
this is Ted again, just to follow on to Raul's comment. My concern here would be for the, I think one of our charges as a board is to watch the data, to be careful with taking what we're seeing and start to think thoughtfully about the data and what it shows. Agree that it may not, and trust me when I tell you that I'm no big fan of mandates either. I'd rather not go there if we don't have to. But our responsibility to the public and accountability is to make sure that we're all aware of the data and watching it carefully. So the meeting in 2 weeks, and I'm no big fan of having any unnecessary meetings either, would be for us to do due diligence in looking at what the data says. We can always make a decision at the time based on the data, but I don't think we should probably just ignore the data. And that would be the purpose of meeting in 2 weeks. Make sure that we're on top of watching this and being thoughtful in regards to, do we change anything with what we have? That's my point, and then I'll stop with that.
Madam Chair, this is Al.
Yes, Al, go ahead.
I'm kind of torn here right now, actually, but it seems to me like the best thing we could do right now as a health district is to make sure we get the information out to people. And we're doing a good job of that. People understand that we have an uptick now, and I think that was due to some of the counties taking the mandate off for the counties. I guess what I'm trying to say is I kind of agree with Raul. What Raul is saying is that if we went back to mandates, I think we'd have pretty much a public revolt. I know we would in Valley County, but saying that, they have the right to know that, hey, we have an uptick in numbers. Everybody be more careful. And as far as the meeting in 2 weeks, I don't know if it's really going to accomplish anything, Ted, other than, hey, we need to make sure that people know that it's getting worse again. Protect yourself, on and on and on, that kind of a deal. I'm also sitting here thinking about, I wonder if we could do some kind of a threshold where we get, I don't know, 40%, 30%, 50% of the population is vaccinated. When that happens, then you can start taking your mask off, to create an incentive for people to get the vaccine, instead of rewarding them with not being able to wear them. You don't have to wear a mask once you get vaccinated. Well, once we get a certain percentage of population, and I don't know what that number is, then everybody can take their masks off to create that incentive. I think using a carrot instead of a stick will work a lot better. That's all.
Yes, thank you, Al.
Madam
Betty Ann,
Chair.
I do.
Go ahead.
I'm sorry, who's speaking?
It was Jane. Go ahead.
Okay, go. I was going to say, we, am kind of going along with what Raul and Russ and Elt are saying. If we did see a large uptick in the numbers, we can always have the right to declare an emergency meeting if need be, rather than to schedule one. So, Jane, go ahead.
I was just going to piggyback on what Elt said, and I agree 100% that if we could set goals so that people are encouraging each other to get the vaccine, as well as healthcare providers encouraging them, I think we'd get a lot further.
Okay, thank you, Jane.
Madam Chair, this is Ted again. Just to build
yes.
off of Elt's and Jane's point, maybe we could ask Kim to start tracking another metric, which would be vaccination percentage. I think it would be useful for us to be encouraging vaccination the best we can. And maybe Kim could bring to our meetings kind of a vaccination percentage, and we could just track that as a number as well.
Kim, are you there?
Yes, Madam Chair, I am.
Would you like to comment on that?
I think it's something that I could definitely look into. I believe that there are some vaccination metrics that are currently being tracked by Health and Welfare, so I would need to look into it a little bit more to find out what data is available to us. But as long as I can get my hands on that information, I'm happy to share with the board.
Madam Chair, this is Elt.
Yes, Elt.
Kim, I think, like you said, the state's kind of already doing that now. I can't remember the name of the program, but it would be really cool if we could get a county by county vaccination rate and maybe turn that into kind of a little fun competition to encourage more people to get vaccinated. We're the first county, so to speak, to reach that point, so everybody gets to take their mask off or whatever we decide to do in the end. But like I say, use the carrot instead of the stick, and I think we'd get a lot more return on what people will do. I don't know if you can do that or not, though.
Kim, are those numbers available by county?
Madam Chair, I'll have to look into that. If they aren't publicly available, I'm happy to reach out to our health and welfare counterparts to find out how granular of data they're able to provide.
Okay, thank you. Any further discussion? Russ, do you want to comment before we move on?
Madam Chair, I don't have anything to add other than the points that were made, the opportunity to call an emergency meeting if needed. Certainly we'll look into the vaccine data. As Kim noted, it is published on the state website. I know it's published by district and by county. What I'm not sure about is if it will identify actual individuals who are fully vaccinated, because as everyone knows, if it's vaccine counts, it doesn't necessarily relate to first dose, second dose. I do know they track by second dose as well, but now you have the Janssen vaccine in the mix, and it's a single dose vaccine. So we'll just have to look into that more and make sure we're comfortable with the data that we're reporting out to the board.
Can you tell us what website that is?
Yes, it is the Idaho coronavirus website, and there's a section for vaccines.
Okay.
Okay, thank you.
They have it laid out as far as the entire state and by health district and by county. You're able to see that data.
So it may be pretty easy to do.
Right.
Yeah. Okay, well, it sounds like the consensus of the board is to watch the numbers, and if necessary, we do go ahead and call an emergency meeting. Otherwise, we institute the measures we have been discussing. Is that correct? Okay, hearing no further discussion, I'd like to go back to Natalie Bodine's report on vaccine status and distribution update. Natalie, are you there now?
Madam Chair, this is Natalie. Can you hear me?
Yes, I can. Thank you, Natalie. Welcome.
Great. Thank you so much, and apologies for the audio difficulties, and a huge thank you to Ed and our IT department for getting me back online. So good morning to everyone. I'm just going to give a quick update on our vaccine planning and distribution for Central District Health, an update on our enrolled providers and what kind of capacity we have in our jurisdiction yet, another look at our vaccine distribution timeline that has recently been updated, our weekly vaccine allocation numbers, and then take a little closer look at the retail vaccine program that is providing some good doses of vaccine into our jurisdiction as well. And then I'll wrap up with just a quick look, and quite timely given the last conversation on the state's vaccine data dashboard that I believe will have some of the information at a county level that is now available on the state site. So next slide, please. So an update on our current enrolled providers. Of course, Central District Health strategy for vaccine allocation and distribution is to work with our current enrolled providers that have that capability and have been approved to receive and administer COVID vaccine. I did actually take a look at these numbers this morning as that report is updated Monday, Wednesday, and Friday, and we do have a change in the numbers from the slide. We are actually at 138 enrolled provider locations, and pending provider locations are now at 5. So we had 3 just from yesterday that were moved from pending to enrolled status. So in looking at these numbers, again, it just shows that we do have a lot of healthcare providers out there that are approved and have that ability to receive vaccine as soon as that vaccine supply increases. So as of earlier this week, we are currently allocating with our vaccine supply to around 29 provider locations. And as that increases, we are always looking to bring on more enrolled providers to provide that vaccine to and have more access points across our jurisdiction. So again, just a review, providers that are enrolled include our health systems, pharmacies, FQHCs, family medicine, and other outpatient clinics. We have some dialysis clinics. Of course, Central District Health is an enrolled provider, BSU Health, and more. So we have a good selection of providers to work with that are all eager to get going. And the vaccinating providers that are currently receiving an allocation of doses from Central District Health are listed on our webpage at cdh.idaho.gov. Next slide, please. So this is a look at the Idaho's vaccine distribution timeline, and this is specific. We will be looking at Group 2 and into Group 3. So as of February 1st, Group 2, Subgroup 2.2, the adults 65 and plus of age and older, became eligible per the governor's announcement. And then per the governor's announcement, Groups 2.3 were made eligible on March 15th. But for Central District Health, due to the drop in demand from Group 2.2 towards the end of February, early March, and an increase in vaccine supply, and then also working with and hearing from our healthcare providers that they had open appointments, open schedules, a lot of weekend clinics, Central District Health did make the decision to open up to Group 2.3 a little bit earlier, and we opened that group up for eligibility on March 6th. Next slide, please. So this is just a continuation of those subgroups that fall within that Group 2.3. So our vaccinating providers are all working through the different groups in subgroup 2.3. Next slide, please. So this is our most recent group. This is Group 3. So this is age plus medical condition alternating with age bands. So subgroups 3.5 and 3.6 were added most recently by CVAC and approved by the governor. And this chart here was updated just earlier this week on Tuesday. So you can see that we have started with age 55 to 64, opened up for eligibility on March 15th. And within that age group, it is those with at least one medical condition. And then opening up on Monday, March 22nd, will be age 55 to 64, general population. And then you can see working through the different age bands in kind of a 2-week time frame, where the first week is with those in that age band with a medical condition, and then it'll open up to the general population. And again, as I said, subgroups 3.5 and 3.6 were just added that really look to the rest of our population. So age 16 to 44 with at least one medical condition will open up for eligibility on April 12th. And the general population, age 16 to 44, will open up on April 26th. And of course, local public health districts do have the ability to open up these bands earlier if supply and demand allows. And we will continue to work closely with our vaccinating providers to assess current inventory, what public demand is looking like in these different subgroups, and of course, vaccine supply. So if it looks like we may need to move a little bit quicker, we will certainly consider that and work with our providers to maybe potentially open up a subgroup a little bit earlier. Next slide, please. So this is our weekly vaccine allocation chart, and it's getting a little busy. We are now moving into week 15, which is the week starting on Monday, so the week of March 21st. So you can see here several columns. So we, of course, get our weekly allocation numbers from the state immunization program on a weekly basis on Thursday that we then allocate to our enrolled providers for delivery the following week. So just yesterday, we received our week 15 numbers. Those doses will be delivered next week. So we received 6 trays of Pfizer, which has been consistent from the week prior, and 4,200 doses of Moderna. And then we did get some Janssen doses, which is great. Because you can see from the Janssen, we did get an initial push in week 12 after Janssen was approved for EAU status. And then no doses, and we were told that it would be an initial push, and then it would definitely slow, and then it'll start to pick up again with Janssen. So we are really excited to see that that looks like it might be coming on board a little bit, and we have been told, and keeping our fingers crossed that this comes true, that our vaccine allocation numbers to the state should double within the next few weeks. So anticipating more vaccine into our area. And then on the far right, you can see the different priority groups that we are currently working in and working through. So of course, week 15 on March 21st, that group 3.2 will be opened up for eligibility. Next slide, please. So this is a program I wanted to just provide a quick update on. On top of the weekly allocation that Central District Health receives from the state, there are a few other federal programs that are operating. And this one specific I wanted to talk about, which is the Federal Retail Partnership Program. So this was a program that was activated in Idaho the week of February 11th. There are many partners that are included in the retail program, which include Walgreens, CVS, Rite Aid, Walmart, Costco, Albertsons, and Fred Meyer. Currently, right now, the program is activated and is providing doses direct from the federal allocation to Walmart, Albertsons Save-On Pharmacies, and Walgreens in our jurisdiction. So this is really providing a good surge of vaccine into our area on top of the weekly allocation numbers the Central District Health gets, which is great. It just opens up more access points and more vaccine supply. So you can see the breakdown there as of March 11th in total for our jurisdiction. Through the Retail Pharmacy Partnership Program, we have received just over 33,000 first and second doses. And you can see the breakdown there between Ada County, Elmore County, and Valley County. Next slide, please.
Natalie, this is Ted Epperly. Just a quick question on that last slide. Could you go back to that for just a second? I don't see Boise County listed. Was that just a miss, or have they not gotten any through this program?
They do not, sorry, Madam Chair, this is Natalie.
Yes, Natalie, go ahead.
Yes, Dr. Epperly. So Boise County does not have any pharmacies that are enrolled in the Retail Partnership Program.
Okay, thank
Natalie, this is Betty Ann, if I may interrupt. I do see that there are mobile units available. Maybe that would be a consideration for Boise County to have access, if we could look into that.
Yes, Madam Chair, this is Natalie.
Yes.
Yeah, absolutely. And we have been working with Albertson Save-On pharmacies that are doing mobile clinics and have done a couple up in Idaho City already. So definitely, we do have pharmacies that are working within Boise County.
Okay, great. Thank you.
Next slide, please. So this, I just wanted to provide a quick snapshot of data that is provided from IDHW on their vaccine data dashboard. And this can be found on the coronavirus.idaho.gov website. So this is the data that is extracted from IRIS. And the slide that you see here, this data was updated on March 16th, so just earlier this week, and just wanted to show that for the jurisdiction for Central District Health, it is showing that we are currently sitting at 86% for doses administered. So distributed doses for our jurisdiction, which includes first and second dose numbers, is just over 178,000, and then doses administered is almost 153,000. So this is the only slide that I pulled from the vaccine data dashboard just to give a quick look as to where Central District Health is sitting. But if you go to that data dashboard on the coronavirus.idaho.gov website, you can sort and look at number of people vaccinated who are fully vaccinated and people who have received at least one dose of a 2-dose series by county. So I would definitely recommend checking that information out on that dashboard. And again, I believe that is updated 3 times a week, and the information comes out of IRIS. Next slide.
Madam Chair, this is Elton.
Yes, El, go ahead.
Natalie, if you could go back to the next screen, is that the 86%? Is that basically, if you look at it another way, there's 14% of the doses that are out there that are available for people to go in and get a vaccination? And I'm assuming those would be in like pharmacies and Albertsons and those kind of places. Is that how I should read that?
Madam Chair, this is Natalie.
Yes, Natalie, go ahead.
I'm sorry, Commissioner Hasbrook, could you restate your question? I'm not quite sure.
I'm kind of hung up on the 86% administered. That tells me that there's 14% of doses left still in the system to go out. Is that correct?
Madam Chair, this is Natalie.
Yes, Natalie, go ahead.
I would have to look further into some of the other data points to get a good number off of that.
Madam Chair, this is Russ.
I'm not understanding.
Yes, Russ, go ahead.
So what you're looking at is data from the immunization reminder information system that the state manages. So to Elt's question, if you take 178, subtract 152, are there that many doses out there available? And the answer is it would be something near that, likely less than that, because vaccines are being administered right now. As we're having this meeting, it's updated 3 times a week. The other issue is to say all of those doses are available to the public. Most of our providers have their appointments booked out for first and second doses.
Okay.
So they're not readily available for that reason. So we don't have an exact number. What we do continually is encourage the public to reach out to one of the enrolled providers, including primary care providers, our major health systems, Cascade Medical Center, St. Luke's up in Valley County, for example, to schedule an appointment through them. They all have their own scheduling systems, and we're not directly involved in that. Our job right now is to allocate the vaccine out to the enrolled providers, and we try to keep them at consistent levels or increasing levels depending on the amount of vaccine we get, as well as certain providers if they are sitting on a lot of inventory because they're not able to book out their appointments, then that might be a reason. We'll talk with them, and they'll usually say we're good for this week. So we maybe don't allocate, but it's not they're not getting their supply chain is not disrupted. It's just a matter of managing their vaccine according to the priority group set by the governor. Hope that makes sense. I know it's a lot, but the bottom line is there's not that many doses out there available for the public for all the reasons I mentioned, but there's plenty of vaccine for sure. And we're seeing increasing quantities on a weekly basis coming to us, as well as separately through the retail pharmacy program that Natalie spoke about earlier.
Thank you. That answered my question.
Okay, thank you, Russ. Any further discussion points or questions for Natalie? Okay, hearing none. Well, Natalie, thank you so much for your report. And I think at this point I will call for a 10-minute break before we proceed with the remainder of our agenda. So we will reconvene at 10 minutes till the hour.
Madam Chair. Madam Chair.
Yes.
This is Representative Blanksma. If you want an update from me, I need to do it before you break because we need to go on the floor.
Okay. Thank you for your input, Megan. Go ahead. And yes, we would like an update from you.
Okay. So from what I understand, they are holding the changes that you guys requested as far as funding public health districts. I don't know if that is going to come out of committee or not. The rumor right now is it is not because of the unwillingness of some to eliminate the CAT and indigent funds. So that's where that is sitting right now. But it is over on the Senate. It did pass the House side. Right now, we're dealing with 6 legislators that are out with COVID. We're anticipating doing a recess of a couple of weeks so that people can appropriately quarantine if necessary. But right now we're trying to figure out the best way to do it. So that's kind of the update from here. So everything is going to sit if we can manage that. And then I don't know what else as far as questions for me you have. I'd be happy to answer anything though.
Madam Chair, this is Russ.
Yes, Russ, go ahead.
We have a number of bills we're going to go over, and then Al can share what has been going on among the Executive Council of the Public Health District working with Mike Kane. But the one question, while we have Representative Blanksma on the line, is there is a bill, House Bill 73. It's quite a long bill, but there is one section that I wanted to bring to the board's attention. As you recall, about this time last year, we had a discussion among the board about making a request to the Legislative Council to discontinue using the Legislative Services Office for our audits. And we were doing that, as you recall, for 2 reasons. Number one, Legislative Services Office charges more than twice the amount that we are able to secure through a private auditor. So that's number one. It's twice as expensive. Number two, and this is not just specific to our district, But the delay in the audit reports coming from the Legislative Services Office after they've completed their on-site work at times has exceeded a year. So I went under the board's direction to the Legislative Council last June to request an exception to this so that we could secure an audit from an outside firm. So we are actually in the process of doing that, working on a contract to allow that to happen. And House Bill 73 includes language in there that changed Title 39, Section 414A, so that audit must be made under the Legislative Services Office. So what it did, what my take on that is, it appears to have reversed the exception that we received approval for. So I'd like to hear from Representative Blanksman for the board to hear if in fact, starting on July 1, if we're going to be required by law to once again use LSO for our audits in the future.
Thanks, Russ. Yeah, the answer is yes. Assuming that language stays in. That was an end around by Representative Moyle. He did not like what we did with Legislative Council, and he inserted that language and buried it in a bill that was the transparency bill, and admittedly, I didn't find it in time. And so when I found out that he did it, it was already on the board. So that is the consequence of that language, is to reverse what we worked on in the interim and the agreement that we had to be able to do our independent audit.
Madam Chair, this is Russ.
Yes, Russ, go ahead.
And for the board's awareness, this is to the governor for signature.
Okay, thank you, Russ. Megan, did you have any further comments before you have to go?
No, I would just add that will be immaterial if the changes in the subsequent bill make it through. So then you get your independent audit back in the language that for the change in the funding of public health districts. It's just whether that one will move through the Senate or not. So if you feel like it's appropriate for you to call your senators, that might be a better way to handle that, to figure out whether they're really going to move that or not. But I do know that the last I heard, it was stalled in committee over there.
Madam Chair, this is Ted Epperly.
Yes, Ted, go ahead.
Yeah, a question for you, Megan. I'm very sorry to hear, of course, of 6 legislators with COVID. Do you know what their vaccination status was?
Madam Chair, Ted, I feel uncomfortable commenting on any medical condition of anyone other than myself.
Okay, I understand. Thank you.
No problem. So I'm going to go ahead and click off then, unless anybody had anything else they wanted to know from me.
Okay, thank you so much, Megan, for your input.
Yes, and sorry, it's just, it's a crazy day today, so.
I understand.
All right, thank you for understanding, and you guys you guys have a great weekend. Thank you.
Okay, thank you, Megan.
Bye.
Okay, with Megan's comments concluded, let us go ahead and we will break, let's say, until 10 straight up. Okay.
Now,
Now?
yep.
Okay. All right. Thank you, Dustin. Okay, proceeding with our agenda, I'm going to ask Elle to provide us, Commissioner Hasbrook, to provide us with an update on the Public Health District's Executive Council. Elle, go ahead.
Okay, thanks everybody. We have been meeting usually every Friday at 10 for a Zoom meeting. I think it is District 6, Ken Estep. I don't know if any of you guys remember, he passed away here a while back, and so they've been trying to find somebody to fill that position. Their board chairman has been kind of coming and going to be involved, but basically we talk a great deal about the legislation that we propose. Everybody knows that we worked with Mike Kane and kind of wrote the legislation to move the funding from the state back to the counties. We spent a great deal of time on that. Basically, what it's got to come down to is we think we had a pretty good bill. I went to the hearing at the Senate side, or no, the House side, excuse me, and it passed with a due pass recommendation. Really no changes at all. Now it's in the Senate, and apparently there are some squabbles about, well, we heard the first one about the auditing process, and I'm hoping that maybe with some communication with Mike Boyle, we can get some of that maybe pulled back out. I don't know where he's coming from on the audit part of it, but the feeling I got from the Senate side and from Mike Kane is that it looks like it might go through. Basically what it's going to do is relieve the burden of the counties of pretty much almost all the indigent program, indigent funding, and also the state on the CAP fund. The heartburn that some of us had was that the counties are still going to be the folks that sign these people up. We have the bureaucracy, so to speak, we have the people that do that function, and so someone that does come in and apply for indigent care will go through the county, we'll sign them up, and then I'm assuming that paperwork will just be sent to the state, and the state will make the decision whether or not they're going to pay for that kind of stuff. I think in the end, what is going to happen with it is, if it does get passed out of the Senate without any more changes, the hospitals are going to be more on the hook to collect bad debt, and it's not going to be up to the counties or the state to pay that indigent claim and then lien on that person forever and ever and ever, and hopefully someday get money back. So I'm kind of excited about it. You know, who knows what the Senate's going to do with it. The other bill, and I think it was 317, I'm not sure the number on it, was the bill that basically allowed mask mandates to be determined by the county commissioners. County commissioners will be the final say on whether mandates are available or not in the county, not necessarily the cities, but in the county. And that bill passed both houses and is actually sitting on the governor's desk right now for signature. I have not heard if he signed it yet or not. Other than that, there's not going to be any IAB again this year. I think we're going to try and do a half-day Zoom sometime in June, but we'll let everybody know when that does kind of happen. I kind of think it's going to be a pretty short, sweet IAB this year for all the boards. There's been a little bit of discussion about, okay, if the funding is going to be coming off from the counties, do we even need the trustees anymore? Because the trustees were, of course, the ones that set the funding formula. So there's been discussion about some of those responsibilities of the trustees will probably go away. But we will be more, I think, a political board or a political group than more, management and budget and that kind of stuff. It may even come to a possibility that the executive council could completely go away. So those are things that are still in the future. We're still kind of talking about that, but I can tell you it's been really tough being on both sides, on both boards. But coming from a county commissioner's perspective, I'm really excited because it gives us more local control. And of course, you guys that are appointed by your commissioners to serve on this board are going to have to build that relationship with your county commissioners. And if you want some of these things, they're the ones that are going to have the final say on it. And because they're an elected official, they'll be the ones that will ultimately pay on the next election if the public likes it or not. So keep that in the back of your mind. I think that's about all I have unless I've forgotten something else.
Madam Chair, this is Russ.
Yes, Russ, go ahead.
Yeah, I just wanted to say before we go on to the next agenda item, certainly you can open it up for questions for Commissioner Hasbrook, and then I have several bills I'd like to run through real quick to a public health significance, if that's okay with you.
Absolutely.
So if board members have questions for Commissioner Hasbrook, you're welcome to ask those now, and if we have none, then I'll move on. Okay.
Any questions for Alf? Hearing none, I will go ahead and we will proceed with the Public Health District Resolution Report and discussion with Russ. Russ, go ahead.
Madam Chair, I'm sorry, I wasn't clear. So I was going to wait for the board to see if they had questions about the bills that Commissioner Hasbrook discussed. Before we go to resolutions, I have a list of bills I would like to share with all of you, and I'll go ahead and start that now since there were no questions, if that's okay.
Oh, absolutely.
Sorry about that.
Go ahead.
Yeah, so there's a couple I'll start with that are not COVID related, but of public health significance. And one is a bill, it's House Bill 249 on essentially sex education in schools. There's obviously a lot more to what we do, from puberty classes to junior and senior high school classes about healthy relationships, but nonetheless, it kind of gets folded into sex education. So House Bill 249 passed 56-12 out of the House. And what that bill essentially does and the impact on public health is up to this point and forever, as far as I know, parents were given the opportunity to opt their student out of a sex ed class. So I want to repeat that. So always parents have been given the opportunity to opt their student out of these classes. In our district, for perspective, less than 1% of parents do that. Most parents are fine with their students attending these classes. And we work very closely with the schools. We give parents an opportunity to review materials ahead of time should they choose. We work with school health teachers, school administration, certainly if we make any changes to the curriculum. So what this bill does, it's now headed to the Senate Education Committee, is it will require, in our district, 99+% of the parents in writing opt their student into sex education. And there's a number of concerns I have with that. Number one, especially for older students, getting that form home, getting the parents to sign it and getting it back to the classroom can be a challenge. That's an understatement. So my concern is there are students who could benefit from this who will miss out because now the burden is on them to opt in should this pass. So just make you aware of that. I don't know if it'll pass or not. It's not the first year this has been introduced. Bill number 2 is a tobacco bill, Senate Bill 1087, passed out of the Senate on Tuesday by a 25-10 vote. And what this bill does is it would raise the minimum age to purchase tobacco in Idaho to age 21. Interestingly, President Trump in December of 2019 already signed this into federal law, so it already applies. So I guess the state's doing a little catch up to make sure their laws are in parity with the federal law. Next, and Commissioner Hasbrook talked about this, but I just wanted to provide a little bit more clarity on it. It's Senate Bill 1060. This bill has gone to the governor for signature. So if in the future, if the governor signs it, basically as soon as he signs it, this board issues either a county-wide or district-wide orders, the affected county is required to review that order and by resolution determine within that 7-day window whether or not they approve of the order. So essentially, if you all, this board, were to pass an order today for Valley County, Within 7 days, the Valley County Commissioners would have to put that on their agenda and make that determination. So the order could be lifted by the county, it could be amended, modified, and then if it is approved with or without modifications, it will stand for a period not to exceed 30 days. So the Board of County Commissioners by the affected county would take that issue up every 30 days and make a determination whether or not that order would continue. So that, if the governor signs it, will be law. Next.
Well, before you move on, Madam Chair, this is Al.
Yes, Al, go ahead.
I just want to explain some of the backstory on that last part, on the 7 days and by the county commissioners. Some of the alternatives that we were hearing was then if, because people that are appointed to the Central District Board of Health aren't necessarily elected officials, then that's why they came up with this idea, then let's give the final responsibility to the county commissioners. If we didn't support this bill, the next thing we were going to see was that only county commissioners could serve on the health board and one doctor. So there would be, I think in our case, 4 people we would lose on this board the next time around because they have to be replaced by an actual county commissioner. So this is kind of why we settled on the final authority back to the county commissioners. I didn't want to lose all you good people. So that's kind of some backstory. Now you can go ahead.
Before you go on, Betty Ann, can I ask one question on this?
Yes, Ted, go ahead.
Yeah, thank you. Thanks, El, for that backstory as well. Just a question around timing. Some things that are public health emergencies need to be acted on probably faster than 7 days. 7 days could be a long period of time. Let's say there was some sort of major flood that created, swamped the our wastewater facility plants, and it led to a public health outbreak of infectious diseases. Elt, is there a provision there somehow that this could be handled quicker than 7 days? Is it up to 7 days, or is it something that is a 7-day window for them to make a decision on?
Madam Chair, this is El.
Yes, El, go ahead.
Ted, we actually talked about 10 days. We give us at least 10 days. That gives us time to get an agenda for the next meeting. And then we realized you can do an emergency agenda if you give 24-hour notice. So we settled back on the 7th day. But the main thing to remember here is this only deals with basically mandates. We didn't want to be involved in, if they said, you know, Cascade Reservoir has got a major algae bloom, and so we want to mandate that everybody stay out of there, don't swim in it, don't take your dog in. We didn't want to be involved in those kind of conversations. We felt like that was the health district function, not a county commissioner. It deals mainly with just the mask mandate, because there's so many folks in the legislature that are really upset. You guys have seen stuff they've done to the governor to take away some of his authority, and they're trying to take some of the authority, well, they have from the health districts, so basically put it back on the county commissioners to make those final decisions. And I'm okay with that to a certain extent. At the first, I was concerned about we're really gutting the authority of the health districts, but in a way, they never really had that authority in the first place other than as a recommendation. If the cities do, and the cities I think can still do a mandate, but this is very specific for mask mandates only, right?
Thanks, El, that helps. Yeah, thank you.
We don't have to do for like, if Cascade Reservoir or some, what else was there? That's what I remember.
Madam Chair?
Yes, Russ, go ahead.
So what Commissioner Hasbrook is talking about is there were some bills, I think multiple bills that were addressing restricting local boards of health or Department of Health and Welfare, and I believe even the cities, from issuing mask requirements. What this bill does, 1060 does, to address, I think what your question was, Dr. Epperly, is the effective time frame. So if this board were to issue a mask mandate, closure of bar requirement in a county or district-wide, that order will go into effect immediately. It's within the 7-day period that the Board of County Commissioners essentially have the opportunity to say we support it or we don't. And if they say we don't, then it gets overturned. So it's for county-wide or district-wide, affecting the entire population. It's not to deal with your authority or my authority for a person with active TB who is not following our recommendation to isolate, or the blue-green algae bloom in Valley County in the Cascade Reservoir, or, but again, the key point here is your orders will go into effect immediately, assuming that's your preference. It would just be within that 7-day window, the county would have the opportunity to overturn those orders. And then subsequently, every 30 days, it must be reviewed.
But
Thank you, Russ.
it doesn't deal with the algae blooms and that stuff.
Correct.
Yeah, and then the other, sorry, Madam Chair, this is all again. The other thing was the 30-day renewal. If the county commissioners don't renew it in 30 days, you know, they have to do that function as well. So it keeps everybody in the loop and kind of paying attention, so to speak.
No, one last thing on that particular bill, again, it's to the governor for signature, is it changes the violation from a misdemeanor to an infraction. And I do know that was a point of issue for our law enforcement agencies in enforcing the orders that this board put in place. I do know that the preference would be an infraction and to generally keep people out of the court system for violations of public health orders. So that's another provision of the law, should it be, or the bill, should it be signed by the governor. All right, House Bill 67. So House Bill 67 is now law, and I'll just combine it with House Bill 68, which is now law. 67 deals with K through 12, 68 deals with institutions of higher education. So what these bills do is it will limit the authority to restrict or basically close a school or otherwise limit any aspect of school programs or activities to prevent the spread of a contagious disease. So for both a university and college setting, as well as K through 12, Central District Health, Board of Health no longer has the authority to close a school should there be a major outbreak, for example. It's up to the school boards and the State Board of Education to make those decisions in consultation with boards of health. Again, those are both law. I do want to share with the board and the public, CDH's board has never closed a school or a university. And as far as I know, no health district in the state of Idaho during the pandemic has closed a school or a college or a university. Next is House Bill 74. So previously, when cities like the city of Boise and the city of McCall would issue a city health ordinance, it included the geographical area of the city plus 5 miles outside of the city. So this bill, which is also now law, does not extend beyond the city limits. That's all I have. There was plenty of other bills that were introduced, but none that I'm aware of that are making it through the legislature at this time. Be glad to answer any questions.
Madam Chair, this is Raul.
Yes, go ahead, Raul.
I have a question for Russ. Russ, you say that there has been no closing of schools by CDH or any other health district, but many parents, when they reach out to the schools, they point to the health districts as the reason that they're shutting down the schools. Just this week, I had a parent call who went to an outdoor event, to a track and field event, and they were forced to wear masks when they were sitting next to their family. You know, you have to spread out, you have to properly physically distance, and they're being told that pursuant to CDH guidelines, we're doing all these things. So how do we get the message out that we're not requiring schools to do this? And number two, why are schools requiring in outdoor gatherings for people to wear masks?
Madam Chair, this is Russ.
Yes, Russ, go ahead.
Mr. Labrador, we have always issued guidelines to the schools. We base those decisions on, as you pointed out earlier, the recommendations of the Centers for Disease Control to prevent the spread of the coronavirus, SARS-CoV-2 virus. So schools are in the position to make those determinations, whether or not they implement our recommendations, how they implement our recommendations, but under no circumstances have we, by way of order, required a school to close or behave in a certain way. It's all through recommendations. So the scenario that you described, we still recommend when people are in close contact with others in a public setting that they wear a mask.
In Madam Chair, this is Raul again.
Yes, Raul, go ahead.
So I guess we're playing semantics here, but you keep saying that we haven't shut down any schools, but you are recommending to the schools that they do certain things and the schools are following. So I think to me that's just a semantic game that that we are not the ones who are actually issuing the orders, but you're actually issuing the instructions to them. And number two, what science do we have that says that in an outdoor event, in a track and field event, people that are properly physically distanced should be wearing a mask?
We're not, Madam Chair?
Yes, Russ, go ahead.
Our advisory does not require people does not suggest that people wear a mask when they can appropriately physically distance. And we have never recommended to a school that they closed. We worked with the Idaho State Board of Education. They put the criteria together early on. This board, it was before you joined, Mr. Labrador, we were asked to set up criteria that would align with their recommendations to schools on when they should close, when they should go hybrid. That was this Idaho State Board of Education's determination, not ours.
So, Madam Chair, follow up.
Yes, go ahead, Raul.
Can we contact the schools then and let them know that there's no recommendation that when people can properly physically distance outdoors, that there's no requirement for masks? Because what we're creating is a group of people that there's people that are being told your job is to ensure that every person is wearing a mask, and you have these people that think their jobs are on the line if everybody's not wearing a mask, and they're going around really accosting parents and making their lives difficult when they're actually sitting down next to their family members, properly physically distanced from each other. I think we need to make it clear that that's not necessary. We don't need a bunch of tattletellers out there who are telling everybody to wear masks when they're outdoors. I just think we're creating an environment where people actually don't want to follow orders and want to rebel against the government or mandates because we're going overboard on these things.
Madam Chair, this is Russ.
Yes, Russ, go ahead.
Again, I want to emphasize that our public health advisory, which has been published widely, readily available on our website, communicated through our school liaisons to our schools, that we recommend that the public wear a face covering around anyone who's not a member of their household, and when physical distancing of at least 6 feet cannot be maintained. So, board has suggestions for how much more we can continue to push that we've been doing for weeks, months. I'm certainly open to suggestions, but I will say that schools certainly have the authority to decide how they operate. In fact, that's how it's always been. And even the State Board of Ed never mandated that they do anything a certain way. They pushed out guidance in coordination with the governor's office, Department of Health and Welfare, and for those schools in our district, with Central District Health.
Madam Chair, one last comment.
Yes, go ahead, Raul.
Russ, I know what we have done, and I appreciate the work that you're doing, Russ. I just think that the schools are not listening, and I think it's important that's why I'm making these comments in a public setting, because the schools are getting to the point that they're asking people's names when you go in to a basketball game, or they're saying, who are you here for and what is your name? They're asking for private information. It doesn't matter who's there for anybody. All they need to know is that there were 4 tickets given to particular students, and those 4 tickets were issued. We're creating an environment that just breeds contempt. And I think we need to be a little bit more open. And I appreciate what you have done with the guidance. I appreciate the work that the CDH has been doing. But I think it's important that the schools understand that they don't have to act in the way that they're acting.
Betty Ann, Ryan.
Yes, Ryan, go ahead.
So I wanted to kind of respond to Mr. Labrador's comment. I received quite a few of those phone calls as well when we first had the mandates, and it seems that school superintendents and school officials are using Central District Board of Health as a scapegoat, essentially. They have their own policies. Speaking, my wife was on the school board for here in Horseshoe Bend for a couple of years, and they have their own policies. They make their own decisions. They were very clear to us. Mr. Labrador wasn't part of the board when we had that meeting, but the rest of you will recall that when we had the Idaho State School Board Director down here, she made it very clear that the schools would do what they wanted to do based on the information that they had, and that we had no authority or conversation to be had in that. But I've received the same thing. I've had folks from Ada County school districts call and state to me that the school superintendents are telling them that it's Central District Health that's ordering them to do all of these things, and that they don't have a choice but to follow them. And I think that, to Mr. Labrador's point, if we can find a way to clarify that so that folks start bringing that to their school boards rather than bringing it to an entity that can do nothing about it. For example, even if we dropped everything today, the whole 9 yards, and we went back to how we were last March, the schools can still make their own decision to continue to require people to wear masks and social distance and all that. So the big thing is just trying to figure out how to get the public aware that it's not Central District Health, that they need to go to their school board meetings and have that conversation, because we don't control the schools.
Okay, thank you, Ryan. Any further comments? Russ, does that conclude your discussion on the potential, the legislative issues?
It does, Madam Chair.
Okay. All right, we will proceed with agenda item number 7 then, a discussion and vote on public health district resolutions. Russ?
So the resolution concept is based on the idea that local boards of health have an opportunity to generally try to influence policy. Some resolutions historically haven't been really directed toward a specific policy, working with cities, for example, or working with the state legislature, working with counties on county ordinances. So each year, individual boards have the opportunity to submit a resolution which essentially has a bunch of whereas statements to justify the be it resolved statement, which is the action step. So, for example, this board supported a resolution for increasing the age to purchase tobacco in the state of Idaho, age 21. We then share it with the other district boards of health. They can weigh in on it, but it's your resolution, the same as if another board were to submit it to us and the other peer boards around the state. At the June business meeting, the resolutions are discussed, and at that time, there's a decision whether or not to approve the resolution as written or with consensus of the full body, all board members from around the state, local board of health members, to modify that and push it forward, or it fails. I shared the packet of resolutions with all of you via email. Those would have included ones that were archived, either they've been acted upon and resolved. Tobacco 21, for example, would be one of those, as well as the ones that are currently active. And we generally have kept them active for 3 years and then they archive no matter what, unless they're reissued. So for today, again, I don't remember when exactly I shared this with you, probably a few weeks ago. If you have ideas or resolutions that you would like to have considered by the Idaho Association of Local Boards of Health, I would like to hear those today. And then our team here will craft the resolutions and run them back through you for review and approval. And then we'll share them with the other boards of health to be considered at the June meeting. So I'll stop there, Madam Chair, and I'll wait for input from the board.
Okay, thank you, Russ. So any board members have ideas or suggestions for resolutions?
Madam Chair, this is Al.
Yes, Al, go ahead.
I just think you guys need to kind of know, the Idaho Association of Counties, the Idaho Association of Cities, there's a lot of different boards similar to ours that have a lot of resolutions, and it's kind of been passed around through the Idaho Association of Counties that because of the coronavirus, are not able to get together and have these face-to-face conversations with some of these presenters of new resolutions, that everybody's kind of putting everything on hold for the year until we can actually get back together and really sit down and negotiate these things, because they're really an intent of what you would like to see. It's kind of an open letter to the legislature, your letter, and how you feel things in the future might want to go. I would recommend that we kind of put everything on pause this year, because we are not going to have IAB. We are not going to get together. There's not going to be a real fair representation of board members throughout the state on that. But it certainly could still happen if you're very strongly about a resolution. But right now, I don't think Russ or any of the other district directors need the extra work to draft that and put that all together. But if you feel strongly, go ahead and present it. It's part of that function that we do at IAB every year. So just keep that in mind.
Madam Chair, this is Ted.
Go ahead, Ted.
Yeah, thank you. I totally agree with you, Elt. I'm kind of resolved out myself too. I think we're all exhausted, quite frankly, by coronavirus and COVID-19. And I would agree that we take a pass for this time. There are a lot of issues that we could start to tackle, but right now it's still COVID-19, COVID-19, COVID-19. So I hear you loud and clear, and that's kind of where I'm at as well, Elt.
Okay, thank you, Ted. Any further thoughts? Russ, do you have a final comment on that? Is that
Madam Chair, I am perfectly fine with that decision.
okay? Thought you might be. Okay, so that will not require a motion or a vote. Proceeding on with our agenda, we'll have a discussion and vote on the 2022 budget guidance with Russ. Russ, go ahead.
Thank you, Madam Chair. And just real quick to review the process. The March board meeting, what I do is I make a request to this board for budget guidance, which I'll get into here in a second, for the next year's budget. So that in this case, it will be fiscal year 22, which will start July 1st of 2021. After I get guidance from you, we will develop the budget based on what we determine we want to include. I will bring that back to the board for approval on April 16th. Subsequent to that meeting, I present the preliminary, the proposed budget to each of our counties. And I always invite board members, if you're not already a county commissioner, to participate in those. That's not a decision-making process, that's informative. And then on May 21st this year here in Ada County, the budget committee, which is made up of the chairs or their designee from each of the counties, get together and vote on the final budget. So that's the process. So primarily there's two focus areas for the budget guidance that I'm looking for. One is staff salaries, change in employee compensation, and the other is the request that we make to our counties. And I'll go over what I'm requesting the board's approval for CEC, and then we'll talk about what I'm going to request for our county increases. So I just want to share some information with you on staff salaries. So the State Division of Human Resources does an analysis every year comparing Idaho state employees, which we are not, but we do use their services at this time, and they compare our pay rates to the private sector. They also compare us to other neighboring states. So for perspective, right now, the total compensation analysis, because there's a lot of debate around, well, Central District Health or state employees, they get great benefits, and private sector employees, some instances don't. So considering all that, we're 21.5% below the private sector market average. That's 21.5%. This latest report, 2022 CEC report, change in employee compensation report, looked at neighboring states, looking at that policy rate, that midpoint rate. We're 13% behind the state of Washington, 9% behind the state of Oregon and Nevada, 6% behind Utah, and we are even behind the state of Wyoming by 2%. I also want to share the top reason that we are turned down for job offers here at CDH is because of compensation. And I don't think it's lost on anyone. Won't go into great detail, but our staff have worked harder and more hours this year than we ever have. And that continues to this day. It's certainly not over. 60, 70-hour work weeks, evenings, mornings, early mornings, weekends. And I feel strongly that we need to fairly compensate our staff, not only based on the data I shared with you for the assessment comparing state employees and private sector and us to neighboring states. But again, the work effort, the hours with family lost, vacation that was lost because people couldn't take it. You can only accumulate so many hours. And I also, the other thing I want to share is we collect data from all 4 of our counties. So Human Resources collects that year after year. We've been doing it for I don't know, 10, 12 years from our counties. So we look at what our counties are paying their employees because I think it's really important to make sure we don't get out ahead of them, but also that we don't fall too far behind. And that's the information I will share with you before the next board meeting. It'll be part of the board packet, so you can look at that as well. So what I'm requesting the board's approval to build a 4% increase in our personnel budget for fiscal year 2022. These are not across the board increases. These are merit-based increases. That's always been my philosophy, and I think the board has supported that. Those employees who get higher ratings should get a larger increase than those who get lower ratings. So we have a 4-tier system. Does not achieve, which is the lowest level. Very few employees would receive that. They have to have be performing substandard. They would receive no increase. And then it goes achieve, solid, sustain, and exemplary. Exemplary being the highest level. So in this case, if this were approved by the board, and again, I'm asking for your approval to build it into the budget. It'll ultimately be your decision on this at the April meeting, and to make sure we can bear this added cost financially. Some employees would get a little more than 4%, some would get a little less than 4%. So that's on the change in employee compensation side. I can pause there before I go on to the county request to see if you have any questions.
Betty Ann, this is Ted.
Yes, Ted, go ahead.
Yeah, Russ, directionally, I totally agree. I'm in support. Just personally, I recognize this isn't a vote today, but of the direction of a 4% merit increase to be applied across the organization as you and the directors see fit per the guidelines you said. But I think as a budgeting for the fiscal year 2022 budget, putting in a 4% placeholder makes sense for all the reasons you've said.
Madam Chair,
any further? Yes, El, go ahead.
You know, I agree with Ted. It's not that your folks don't deserve it. I think everybody deserves a raise. But you've got to keep in mind, and right now I think we're okay, but Senator Rice has been trying to manipulate legislation that the counties can only increase their budgets by a certain percent, anywhere from 3 to 5%. That's been kind of tabled for the summer, but now that, you know, and then the other issue is we got to make sure that this bill gets through the Senate on the counties taking over funding of all this. So what it's going to come down to is, you know, like Ted and Jane, you guys are going to have to go back to your county commissioners and fight for this increase in their budget so that this can be funded. So keep that in the back of your mind. Normally, we usually get an increase bump every year of about 3%, which is okay for counties, and it's usually been works really well for the health districts. We found out about 5 years ago that we were falling further and further behind at the county level. And so we did some readjustment of programs, closed the juvenile detention facility, and took those funds and gave everybody a 6 to 8% raise over a 2 or 3 year period, which brought us back up into that mid-range of the salaries compared to other counties statewide. And I'm glad that Russ is doing this salary survey. That really kind of tells us where we are as far as how we're paying our folks. But I think we, and I think he should proceed with that budget, but keep in mind that if this bill fails in the Senate, it doesn't get approved or it gets shoved in a drawer for the summer, we're still relying on that state funding then again for another year. So there's a lot of a lot of variables right now that we got to make sure we got everything lined up before we get too deep into it or promise folks something that we can't provide. So that's all I got.
Madam Chair, this is
Yes,
Raul.
go ahead, Raul.
Just a point, somewhat related but not related. The legislature just announced that they are recessing until April 6th. So they announced just a couple of minutes ago. The House just announced that, and they said that they're going to be in concurrence with the Senate on this issue.
Okay, thank you, Raul.
Maybe.
Okay, Russ, on our agenda, you have this listed as a discussion and vote. Do we need a motion? Yes.
I wanted to finish my request for the county portion. So I just covered the CEC idea. And is that okay to proceed with that?
Absolutely. Go ahead.
So, thank you. And I think for all the reasons that Commissioner Hasbrook has mentioned, you got bills, it seems like every year, right, to adjust what the counties can and can't do as far as tax revenue. This year, it sounds like that bill was tabled, but we do have 316 still in play, even in light of what Mr. Labrador just shared. It probably will be taken up the first order of business on the Senate side when they reconvene, presumably because it was supposed to be discussed on Monday, this coming Monday. In light of that potential change and the shift in funding to the counties, which hopefully we'll know by April 16th what the status is. I am not asking for the board to approve a budget with any greater than a 3% increase from our county. So I'm still asking for a 3% increase from our counties to build that into the budget. That's the second component of the budget guidance. Again, with all the uncertainty, we've tried to stay consistent. As Commissioner Hasbrook and many of you know, from year to year for a 3%, we're going to identify that through other funding streams. We've been really successful in getting a lot of new grants and some operational changes here that have allowed us to be more efficient and generate revenue in different ways. So that's the second point. So first, I guess as a package, I'm looking for guidance from the board for us to build into the budget, if we can, a 4% overall CEC for our staff, and second, for a 3% increase from our counties.
Okay, and you want that two separate motions?
Or one.
Or one? Okay.
This is Al.
Okay, go ahead.
Keep in mind, you guys, too, that we need to talk, too, about any kind of merit pay or bonuses. We can't do that until this law gets changed for our district director. So keep that in mind as well, because that got taken away from us last year. So everybody get a hold of your senators, representatives, and make sure that this bill gets through the Senate pretty much unchanged, and I think we'll be okay. But I'll make the motion then that we authorize Russ to go ahead and build a budget with a 3% county increase and perhaps 4% with a 4% CEC at this time as a pre-budget, I guess you might say.
Second. This is Ted. Second.
Okay. Thank you, Al. Thank you, Ted. Any further discussion before I call for a vote on the motion?
Madam Chair, this is Jane.
Yes, Jane, go ahead.
It might be helpful for us to have a long-term plan like Elt was mentioning, so that they could see that we wanted the 3% and the 4%, but if we had a general number for more like 3 years at a time, that would give them some flexibility as they were looking at it as well.
Are you talking about salary increases, Jane? Because the counties are already capped at 3%, as I understand.
I'm talking about us asking for the funds to do the 3 or the 4%.
Oh, okay. Okay, so salaries. Okay. Any further discussion before I call for the vote? Hearing none, I will call for the vote from Valley County.
Commissioner Hasbrook, aye.
Boise County,
Commissioner Sturm, aye.
Ada County, Dr.
Jane
Young,
Young, aye.
Dr. Epperly,
Ted Epperly, aye.
Mr. Labrador,
No.
Elmore County, Megan is gone, so we have a majority, and the motion does pass for giving Russ direction. Okay, moving on with our agenda, we do need a district director report by Russ at this time.
Okay, Madam Chair, thank you, and I'll be quick. The next meeting is Friday, April 16th, as I mentioned, and there's two agenda items that I wanted to call to your attention. Obviously, we're going to talk about COVID and vaccine distribution and cases and hospitalizations, but first will be the board will vote on the budget that we will build based on the guidance you provided today. So that'll come out to you well in advance of the next meeting. And then second is my annual performance review is due. So we're conducting a climate survey that you all are familiar with, who've been here for Mr. Labrador. That's something we've done to get feedback from our staff. Everybody has the opportunity to fill that out, and that survey will be provided to the board, the results. Our management team will have an opportunity to actually complete an evaluation. So it's kind of like what you hear as a 360 evaluation. That will also be provided to you, and you all will be provided an opportunity to complete a very similar performance evaluation. So collectively, you'll have all that information ahead of the April 16th board meeting. And that is all I have, Madam Chair.
Okay, thank you, Russ. That brings us to the conclusion of our agenda for today's meeting. So I will ask for a motion for adjournment.
Betty Ann, can I just mention one thing before we move to adjourn?
Yes, you may, Ted. Go ahead.
Yeah, thank you. Betty Ann, based on your comment earlier about us keeping our eyes and ears open for the data to potentially have an emergency meeting based on the data, I'd just like to underscore again that we keep that as a possibility, not a scheduled meeting, but one that we could move to quickly. And Russ, if you and the staff, along with Betty Ann, could just stay on top of that in case we do need to meet sooner than April 16th. And I just wanted to underscore that, Betty Ann. Thank you.
Okay. Thank you, Ted. We will do that. So, okay, motion for adjournment, please.
Madam Chair, this is Ryan. I'll make a motion to adjourn.
Okay, thank you, Ryan. Is there a second?
This is Jane. It's a second.
Okay, thank you, Jane. I'll call for a vote by county, starting with Valley County.
Commissioner Hasbrook, aye.
Boise County.
Commissioner Sturm, aye.
Ada County.
Jane Young, aye.
Ted Epperly, aye. Ted
Ron
Epperly,
Labrador,
aye.
Aye.
And Megan is absent from the meeting. So the motion for adjournment does pass. And I do thank the board for their participation as well as the public who listened in. So we will be talking again on the 16th of April, and everybody stay safe and have a good month. Thank you. Goodbye.
Thank you.
Thank you. Thank you.
Take care, everyone. Bye.